Welcome everybody. Let me kindly introduce my colleague from Bonn, formerly from Malta, Karl Mercieca, the head of the glaucoma department in the University Hospital of Bonn. My name is Karsten Klabe. I'm the glaucoma surgeon at the Breyer Kaymak Klabe eye surgery in Düsseldorf, so we are neighbors. Yep. So we want to talk today about the new canaloplasty up internal device from Nova Eye Medical, the iTrack Advance. Karl, tell us your experiences about, or your ideas about canaloplasty, not only up internal but external as well.
Hi Karsten. Good question. So experience, what defines experience? So I think that first of all, if you think about glaucoma surgery today compared to 10, 15 years ago, we are so lucky to be able to provide our patients with a tailor-made solution for their glaucoma. And therefore, of course, when I started doing glaucoma, same as yourself, probably the ab-externo, probably more invasive procedures were standard, and there was very little in terms of less invasive stuff. Now we have gone the other way. We have so many interesting things, and I think also more thought in what we sort of do. So when it comes to canaloplasty per se, it makes anatomical sense that we have a problem with the Schlemm's canal, the episcleral venous outflow and pressure, and dealing with that makes absolute sense when you're trying to get flow out of that anterior chamber and lowering the pressure, perhaps not to an abnormal level, which is what we do with our trabeculectomies and other stuff. And therefore the anatomy of the canaloplasty makes sense. Now again, in the past you could only really do it ab-externo, which meant cutting through tissues, and now we're very lucky to be able to do this from the inside with a much less invasive technique. So my experience has gone from cutting procedures, doing deep sclerectomies rather than canaloplasty, but it's kind of a similar kind of thing, which is non-penetrating but not less invasive really, to then going to the ab-interno devices, first with stents, like probably you have as well, but also nowadays, especially recently, canaloplasty. So I think we have one microphone, so I'm going to sort of play a game of throwing the microphone at you with a couple of questions. So you mentioned a viscoelastic device. How much? Which one? And would you tell us a few little tricks of how to get your assistant, for example, to really do a good job?
So, last question first. All of my staff is well trained because I'm doing canaloplasty up externo over years. So they feel comfortable with the device, and that is equal to that what we're doing in up externo. So you have to rotate the syringe a little more clicks in a minute. Of course, it's up to 3 to 4 clicks per clock hour, and that means we are, in average, about 200 microliter of viscoelastic. I prefer Helon GV, high viscosity, to give the viscoelastic the chance to remain in the Schlemm's canal. There could be a slightly elevated pressure due to these at day 1, day 2, but usually it works fine with no additional IOP lowering medication. And how about your amount of viscoelastic? You can beat me.
So yes, so I'm relatively new to this, so that's why I'm asking you. But I think you're absolutely right. I think for me it's 3 clicks per clock hour, and I think at the moment that is kind of my feel. As you said, I suppose you can inject more. And probably the more you inject, the more of a widening and potentially more of a result you get. My fear is obviously also, however, that because you have a closed system, you can get breaks. You can, in theory, get sort of decimase breaks. Hyphemas are quite common, but my experience, even talking to colleagues who do external canaloplasty, is that actually hyphema is a good prognostic indicator. Usually, if you have a hyphema, it means that you have dilated the collector channels, you have had some reflux. I don't know whether that's your experience. So if people are starting to use iTrack Advance and they realize they have a few hyphemas the next day, should they be worried about it? What should they do? Any tips, tricks? Do you increase the steroid, decrease the steroid, put them on atropine? What are your really, really nice pearls for this?
A lot of really good points and questions as well. So first of all, high femur. No, it is common. It is common. Nearly half of my patients show a high femur of any size, but most of them are completely resorbed with 1 week. So no problem at all. And if you have a look onto the trabecular meshwork, the high femur, in nearly all cases, the origin is the point of the trabecular meshwork where you introduce your catheter. It's not because of breaking the trabecular meshwork at all. A descemetallysis, you mentioned already, and that is one of the huge differences between up externo and an up interno. In up externo, the risk is much higher because in most cases the pressure in the anterior chamber is lower and there is no visco in. And now with up interno device, we first fill up properly the anterior chamber, and that's why I didn't see any descemetallysis. Of course, we're talking about less than 100 cases. But I've never seen this, and that seems to be a difference that due to the filled anterior chamber with viscoelastic, I use the same, I use Helon GV as well, but that seems to push out the viscoelastic I introduce into Schlemm's canal through the collector channels, and that might be the difference, and that might be the good effect of this procedure itself.
That's really useful tips actually. Regarding the actual surgery itself, do you have any particular tips as to how approach these eyes? Because of course, up externo surgery is kind of more, many people are used to operating from the top, you know, putting the microscope coaxially, you know, making some incisions. This is different. This is angle surgery, so there's a gonioscopy lens, there's head tilts, etc. But what are the real things that make a difference to you to make your life easier and get you the best result for your patient?
So, easy answer. It's all about visualization. So, the management with the gonio prism, tilting the head, the patient's head, tilting the microscope properly, that you have a brilliant and fast view on Schlemm's canal, makes your life much, much easier. The iTrack Advance catheter offers you the ability to turn around the cannula, so you can adjust it to the trabecular meshwork. So use not perpendicular paracentesis, more tangential, and a more tangential approach. We all know from different devices like the Hydros as well. And the introduction into Schlemm's canal is because of the design of the tip relatively easy. So I just puncture, retrack it a little bit, and then slowly forwarding the catheter, and it's so easy, and it runs so fast because this is a 1-2-2 movement. So on the other hand, if you retract it, be really slowly and give your nurse a chance to properly rotate the syringe to add a lot of enough viscoelastic. Yeah. So, but the learning curve, if you are experienced in angle-based surgery, is really short, because most of the steps you know already. So, if you're doing it in combination with cataract surgery, so I'm doing mostly a third side port, especially for the iTrack Advance device. So that's how my tricks to make my life easier. But first of all, a good look on the angle is really important.
I'd like to add on that, because I think that is one really important thing, that you have to visualize things, there's no doubt. A little tip I always give people is when you're actually entering through the trabecular meshwork, increase the magnification, increase the brightness. It enables you to know exactly where you are. Then you can pull back. And I think that is really important. It just fits in with what you've just said. The incisions are really important. So I as well do a different incision, whether it's combined or not. Where you place your incision is key, because you want to be at an angle which allows you to feed that catheter in. So for people who do gonioscopy related surgeries, eye stents, etc., there are some differences in the angle, how many clock hours. I would recommend 3 clock hours from where you're planning to go in. That for me makes sense. And the great thing of this device is that you can actually toggle it. You can change the angle of approach, which enables you, because we are all slightly different, Karsten's hands are slightly smaller than mine, and it makes a difference to how you hold the instrument and how you approach the angle. Interesting, you do way more probably combined than I do. So my question for you is, phaco first or later? And do you change any settings on your phaco? High bottle, low bottle? Do you change the viscoelastic? Do you use a different viscoelastic for the phaco? And then, of course, Helon GV Pro?
By the way, I was waiting for this question already. So I still do all my mixed procedures at the end of the phaco emulsification. So first of all, most of my cases doing cataract surgery are not rock hard. So the cornea is still clear at the end of the surgery, so there is no challenge with any visualization with a gonio prism. And so what I love to have is space. So, and I think space is a key as well. You can do it on an ametropic or slightly myopic eye at the beginning of a surgery. So, there might be in really hard cataract surgery cases or tough surgery cases that the cornea is absolutely clear at the beginning. But as I told you, in most of my cases, phaco doesn't take longer than 5 minutes, including implantation of a lens, and then there is a clear cornea, and I have enough space to be absolutely sure not to damage the iris during my procedure while wiggling or fiddling a little bit. So safety, space, and there is no issue with visualization. How about you?
Yeah, so I'm like you. I tend to do the phaco first, create space, get it out of the way. There have been very few occasions where I've gone in to do the MIGs first. One of them, I'll admit, was a patient whose pupil hadn't dilated because the nurses forgot to put dilating drops in. So I said, let's use that as an advantage, because the only advantage of doing the MIGs first is that the canal is not boggy from the bottle, sort of, so the infusion for those 5 or 6 minutes you're doing the phaco. But overall, get the phaco out. One little tip I'll give you: if, and this is rare, there's a problem with the phaco, say a small posterior capsule rupture, don't proceed with the MIGs. That's my opinion, because you'll only make a small hole bigger and then vitreous comes through. This is rare, but these are little tips that is what we're here to give you today. So I tend to go phaco first, get that out of the way, create more space, and I don't find there's a problem, sort of getting into the canal. The amount of viscoelastic you put into the anterior chamber, you don't want to pump up the eye too hard that you're actually just, plastering your Schlemm's canal. You need to have some flexibility. Of course, you need space to work in. So I think we're running out of time, but I hope that we have given you some really good tips and tricks. The one thing with this kind of surgery is that you don't have to be as good a surgeon as Karsten. You can be as average as me and still do a really good job and get excellent results. And you can also practice, so you don't have to try your first case on a human being. There are dry labs, there are amazing artificial eyes you can use now to practice with practicing your gonioscopy. You can also start practicing gonioscopy on your phacos. So at the end of the surgery, just ask the patient whether you could have a look with a gonio. These are all little things that prepare you for this kind of surgery. But I agree with you, Karsten, that at the end, if you are doing things like phaco plus iStent, switching to Interno Kanaloplastik is not difficult at all. If you strongly believe that the anatomical thinking for canaloplasty makes sense, then there's no reason why one shouldn't switch, or at least think about switching.
Yeah, it's a small step to switch from, if you come from upper external, it's easy doing. If you do cataract surgery as well, there is no border, I think. And on the other hand, you are, for good reasons, the head of a glaucoma department. in a university hospital. So you are not so you are skillful, mostly more than me. No, at the end was an excellent talk about a new device, a new approach in glaucoma surgery, and a non-invasive, less invasive, without any implants, and with a probably new mechanism addressing more of the distal outflow. And okay, time will tell. You always told us that in most of these mixed procedures, we need long-term data. The data we had already are really promising. And so hopefully we can talk about the next year about new devices or about long-term results with these really exciting glaucoma surgery.
Absolutely.
Thank you.
Looking forward to it.
Thank you, Karl.
Thank you. Thank you, Karsten.